Good afternoon, everyone. My name is Abigail Cochran, and I'd like to welcome my fellow speakers as well as all members of the audience today to our webinar entitled Transportation to Healthcare and COVID-19, Exploring Pandemic-Era Travel Trends and Post-Pandemic Opportunities and Challenges. Let's see if you could advance the slide, please. Today's webinar is sponsored by the STRIDE Center. STRIDE is the 2016 US DOT Region 4 University Transportation Center. The STRIDE Center is a consortium of 10 Southeastern colleges and universities with the University of Florida as the leading institution. STRIDE's mission is to develop novel strategies for reducing congestion and otherwise making transportation more sustainable. We at the University of North Carolina at Chapel Hill are so glad to be a part of STRIDE, and we thank the STRIDE Center for hosting this webinar today. I would personally like to extend a special thanks to Ondine Wells for her assistance in organizing and publicizing today's event. I invite members of the audience to contribute questions at any time during this webinar using the chat box. We plan to present for about 40 minutes and then leave 20 minutes or so to answer your questions at the end. We invite questions for all of our speakers individually or as a collective. If your question is meant for a particular speaker, please do specify that again in your submission to the chat box. Thank you so much for tuning in. Next slide. The webinar will proceed as follows. First, I'll offer a very brief introduction of our speakers. Next, Dr. Olivia Wang will present research she led examining pandemic-era travel trends, specifically trends in trips to medical facilities in North Carolina in 2020. Lindsay Oluyede will then present research she led investigating care coordinators' perspectives of transportation barriers to healthcare during the COVID-19 pandemic. After these research presentations set context for some understanding of what we've seen happen with travel, particularly transportation to healthcare during the pandemic, I'll moderate a discussion with transportation professionals who've had the enormously challenging task of coordinating and actually providing safe, reliable transportation in the last 15 months or so. Gathering these practitioners' perspectives should allow us to round out a comprehensive and important presentation about what happened during the pandemic, what they identified as challenge and opportunity areas, and what we can learn from this trying time looking ahead. Next slide. Our presenters today include myself, Dr. Abigail Cochran. I'm a postdoctoral research associate at the University of North Carolina at Chapel Hill. My colleague, Dr. Olivia Wang, is also a postdoctoral research associate at UNC in the Department of City and Regional Planning. Lindsay Oluyede is a doctoral candidate in the Department of City and Regional Planning at UNC. Edward Fishman is a principal of VIA for Health with VIA Transportation. And Herb Mullen is the director of the Inter-County Public Transportation Authority, or ICPTA, which operates in Northeastern North Carolina. Next slide. I'll now welcome Dr. Olivia Wang to present her research examining spatial and temporal trends in trips to medical facilities in North Carolina using mobile device data during the COVID-19 pandemic. Olivia.
Yeah, thank you. Thank you, Abby. Good afternoon, everyone. I'm Olivia. Thank you for being here today. Today, I will present a research work titled as Healthcare Visit During the Pandemic, a Spatial and Temporal Analysis of Mobile Device Data. Lindsay? Yeah, thank you. Timely delivery and access to healthcare are essential for human lives. The COVID has significantly disrupted both our health and the transportation systems, which has reshaped the access and use of healthcare. In the healthcare system side, we see healthcare systems reduce the in-person, elective, and non-emergency healthcare visit during the initial months of the pandemic. Many health providers were temporarily closed during the pandemic because of the financial constraints. The providers and insurers supported the telemedicine visit to replace the in-person visit during the pandemic. On the transportation side, many transportation services, such as the fixed route transit, ride-hailing service, has become less available during the pandemic. These disruptions in transportation would particularly influence the access of healthcare for people who rely on these transportation options. With these disruptions caused by the pandemic, we are curious how different social demographic groups adapted their healthcare use during the pandemic. So we conducted these studies. So particularly in this study, we answered 2 research questions. First, how does the COVID impact the travel demand to healthcare? Second, does the impact vary by the area level measures of social demographic and spatial characteristics? To answer these questions, we mainly rely on the mobile device data from SafeGraph. So the SafeGraph tracks mobile device visit to points of interest across North Carolina via their GPS systems. So we focused on the weekly visit to the medical facilities, include hospitals, office of physicians, and outpatient centers across the year 2020 by each block groups in North Carolina. So compared to the survey data or the medical records data, this mobile device data used in these studies can capture larger scaled human mobilities at that higher spatial and temporal resolution. So we used, Lindsay, can we go next slide? We used the time series clustering to differentiate the patterns of weekly visit to healthcare facilities. So the time series clustering parses the temporal patterns of healthcare visit at block group level into clusters based on their similarities in the magnitude of visit frequency and overall time series shape. The right figure illustrates examples how the clustering works for time series data. In this example, we have 6 time series. So then after the clustering, we got 2 groups. So based on their similarities in their shape and their frequency, their magnitude. So in these studies, we have over 5,000 block groups in North Carolina. So we have 5,000 weekly patterns, weekly temporal patterns, time series data. So after clustering, Lindsay, go next slide, thank you. We identified 3 different clusters. So each color represents 1 cluster. The cluster, we can see these 3 clusters differ significantly from each other in terms of their healthcare visit frequency. The class 1 has the lowest use of healthcare, and the class 3 has the highest. And the class 3 also compared to class 1 and class 2 responded to the lockdown strongly with more reduction, while bounce back immediately when in the early May when the stay-at-home orders were lifted. So, however, the class 1 and the class 2 experienced a slower and more moderate increase after the lockdown. So we further examined how these block groups, social demographics, and spatial characteristics differ among these 3 clusters. So this figure illustrates the percentage of social demographics at block groups among these 3 clusters. Each color represents 1 cluster, which are consistent with the time series figure above of these slides. So we can see the block groups in cluster 1 characterized as low use of healthcare and slow and moderate recovery tend to have high percentage of Blacks and Hispanics and lower percentage of white. Next slide. Also, class 1 has a high percentage of person with low education attainment and a low percentage of person with high education attainment. Next slide. And in terms of household income, we see the class 1 tended to have a high percentage of household in the lowest income categories, but a low percentage of household with the higher income categories. And also expectedly, this class 1 has a high percentage of household without vehicle access. In terms of the spatial characteristics, go next slide, could you? Yes, thank you. In terms of the spatial characteristics, we look at how the cluster distributed spatially. From this figure, we can see there are striking disparities in cluster 1 in the large central metro and the large fringe metro areas. Both block groups in class 1 and class 2, which are characterized as a slow and moderate recovery, are disproportionately located in the central area of metro. And the cluster 3 is more likely to located in the suburban fringe metro area. So for the population density, next, yeah, we also see the class 1 and class 2 compared to class 3 tend to have a high population densities. So to summarize, next slide, please, thank you. To summarize, the studies reveals that all the neighborhoods in this study is our block group experienced a reduction in medical visit during the lockdown, but differ in their extent and recovery patterns. Less advantaged neighborhoods not only have a low use of healthcare across the year 2020, but also experienced a slow and moderate recovery in the medical visit after lockdown. We also see that areas located in the large metro or with a high density had a slow recovery after lockdown. So what do these findings mean? So we see that historical vulnerable populations such as rich minorities and low-income households usually have a limited digital literacy and access. So when the telemedicine became popular during the pandemic, there are a lot of there needed some policy to facilitate the telemedicine available for these neighborhoods. Especially, second is the transportation is this study is also highlighted that there's transportation barriers is still a very key barrier for these groups to access healthcare. So these findings highlight the importance of policy to facilitate alternative transportation options for this group of persons. Also for the neighborhoods located in the central areas with a high density, because these areas are usually the area with disproportionate transit-dependent person who need alternative transportation options to access healthcare. So thank you. That's all my findings.
Wonderful. Thank you, Dr. Wang. I now invite Lindsay Oluyede to offer more context on travel and transportation decision-making at the individual scale during the pandemic with her work entitled Addressing Transportation Barriers to Healthcare During the COVID-19 Pandemic, Perspectives of Care Coordinators. Take it away, Lindsay.
Thanks, Dr. Cochran, and good afternoon, everyone. So I'm going to talk about a qualitative study that examined the transportation barriers to healthcare during the pandemic. Before the pandemic, transportation barriers to accessing healthcare was already an issue for some Americans. In 2017, approximately 6 million individuals reported transportation barriers preventing them from accessing healthcare. The definition of a barrier is a state, condition, or event that makes it difficult or prevents an individual from obtaining care. Examples of transportation barriers to healthcare include lack of access to a private vehicle or public transportation, or those associated costs, the distance and time traveled to reach healthcare providers, as well as the inability to operate or utilize transportation options because of mobility limitations or disability. And so certain populations are more susceptible to experiencing transportation-related obstacles when accessing healthcare. And these groups include individuals with low socioeconomic status, people with disabilities, people of color, older adults, etc. And so then the COVID-19 pandemic happened and disrupted transportation and health systems globally, as Dr. Wang discussed previously. And so the motivations for this study were threefold: to understand the transportation barriers to healthcare that patients encountered during the pandemic, to identify the solutions that medical systems use to address these access challenges, and then also to understand the impacts to those populations that traditionally experience transportation barriers. And so to accomplish our research objectives, we talked to care coordinators. And so these are nurses and social workers and other professionals who help address health-related social needs. Care coordinators often work with individual patients on an ongoing basis, and so they really have this in-depth understanding of their patients' lived experiences with transportation issues. In the fall of 2020, we interviewed 16 care coordinators employed in the Triangle and the Albemarle regions of North Carolina. And so the table on this slide here shows the distribution of the interview participants across various medical specialties. And so that included prenatal to age 5 care, behavioral health, intellectual and developmental disabilities, etc. And among this sample, we talked with care coordinators who work with patients living in urban, suburban, and rural areas. And next, I'll share our key findings. So one takeaway was that the pandemic exacerbated existing transportation barriers. Specifically, it created financial strain and transportation service changes that just built upon these existing transportation barriers. And speaking on this topic, one of the care coordinators said, "People have lost jobs, lost income. The pandemic has just exacerbated everybody's financial challenges." Another takeaway was that the pandemic also created new transportation barriers. Concerns emerged about COVID-19 exposure while traveling with strangers, particularly when using public transportation or ride hailing. And so we heard from one care coordinator that, "I have some patients who are anxious, very anxious, about getting into a ride hailing vehicle. I basically just talk them through it and let them know that the service is fairly safe. They follow their protocols." And during the pandemic, there was this rapid expansion of telehealth offerings, as well as the adaptation of existing telehealth platforms for new virtual services. So for example, a hospital neonatal intensive care unit piloted the use of virtual rounding. So the staff repurposed the telehealth platform that was already being used in the outpatient clinics to allow families to participate in the daily meetings with the full care team to discuss the infant status and treatment plan. And what we heard from the care coordinators is that telehealth is particularly viable for patients living in rural areas, when the patients are infants who are born prematurely or the elderly, and then also for visits that involve preliminary screenings or follow-up visits. But telehealth is not a cure-all. And from what we heard from the care coordinators, telehealth is not suitable, obviously, for appointments involving procedures and treatments. But there are also other limitations, which include a patient's technology skill level and the availability of an internet-enabled device or broadband access. And so one care coordinator said, "The younger patients are very tech savvy. It's easy for them to be able to do a telehealth visit at home. We've done that for behavioral health, primary care, family planning, all of those kinds of things. It doesn't work as well for some of the older patients that we see, as they don't have the technology skills or maybe even have a cell phone or something they can access the telehealth platform with." And so the rapid expansion of telehealth that occurred during the pandemic was enabled by temporary policy changes that eased a lot of the restrictions for telehealth use. And the findings from our study suggest how post-pandemic telehealth policy changes could benefit individuals facing transportation barriers to accessing healthcare. And those specific policy changes include removing geographic and location requirements for providers and patients, widening the range of services eligible for telehealth appointments, and then also allowing for telehealth appointments via telephone, so where there's an audio-only component. And so these policy changes would help to make telehealth a more accommodating and convenient solution for patients and their families. And so with that, I will turn it back over to Dr. Cochran.
Thank you, Lindsay and Olivia, for teeing us up to continue our important discussion of transportation to healthcare during the COVID-19 pandemic with the transportation practitioners who have joined us today, Edward Fishman and Herb Mullen. Before I ask them to offer their valuable insights into what happened in their efforts to continue offering transportation necessary for maintaining health to medical facilities, grocery stores, and nutrition sites, vaccination clinics, etc., during the pandemic, I'll ask them to introduce themselves and tell us a little bit about where they're from and what they do. So why don't we start with you, Eddie?
Thank you so much, Abby. And thank you to the Stride Center for organizing this important conversation. My name is Eddie Fishman, and I work for VIA. We're a transit technology company that works with public transit agencies, with school districts, with paratransit agencies, to put together tech-enabled transportation services. So if you've heard the term microtransit, where people can hail a ride, a shared ride using an app and pay a public transit fare, that's really what VIA does. So we work almost exclusively in partnership with agencies around the country. My specific role at VIA is I'm the lead for VIA for Health. So I specifically work with our public transit partners, with hospital systems, with state health departments to really facilitate access to healthcare by transportation. So this conversation today is very near and dear to my heart.
Wonderful. Thank you so much for giving that introduction to you and to VIA for Health, Eddie. Herb, do you provide an introduction?
Thank you, Abby. Thanks for having us today. My name's Herb Mullen. I'm Director of Intercounty Public Transportation Authority. We're located in Elizabeth City, North Carolina, which is as far northeast in the state, pretty much as you can get as our service area. We cover 5 counties. We're a regional system, and the mileage we cover is a little over 1,000 square miles. We're a demand response system. Again, we're considered rural transportation. We go to the clients' homes, pick them up, take them where they need to go. With a couple of days notice so we can work out the transportation for them. We're excited to be here, and the pandemic was a struggle for us to work through, and but we're trying to get better every day. So.
All right, well, thanks so much, Herb, and I'll certainly ask you a little bit more about that, and hope that, again, the audience as well has some questions regarding where you see things going. So thanks so much to you both again. I'd like to begin our conversation, Herb, by asking you a little bit more about what happened at ICPTA during the pandemic. How did you all experience, identify, and address transportation barriers that your riders were facing?
It was difficult. We were ahead of the curve. When I saw it hitting Europe like it was hitting, and it was moving across overseas as quickly as it was moving, we went ahead and started ordering any PPE we could get our hands on, anything we could do to sanitize the vehicles, so we could go ahead and get it in and get it in stock, because we knew that if it ever came to the United States, that it was going to be difficult to get. So we loaded up with masks and gloves and disinfectant spray and whatnot. It hit New York first, and it really did not hit my area severely till about April of 2020. What directly happened in April was when it hit. We basically said, okay, we can't do any regular transportation, which everything was closing up at the time anyway. Our need was going way down really quickly. But we decided we were going to continue to keep our dialysis and cancer patients and anybody that had a terminal illness riding, even if we had to do one-on-one service. So, we quickly adapted the vehicles. more or less had the drivers quarantined. At the time, we had shower curtains totally around the drivers. We made it to where we did not have any direct contact with the client unless they were of need, if they were in a wheelchair or whatever. And then we made sure that all of our drivers had face masks, gloves, and the proper PPE to get in close proximity to the clients. Our ridership went from, say, pushing 600 trips a day down to less than 100 trips a day. But our employees stuck with us. We had some that were extremely scared and didn't want to work. And we had others that, that they felt comfortable with the PPE that we were providing them, and they felt comfortable with the guidelines. So we never really quit providing service. We just had to provide service in a different manner. Since then, we've seen a total paradigm shift. Telehealth has been huge. Clients, our normal clients, haven't seen the need for us that they saw pre-pandemic because society has shifted so much. To offer at home or telehealth or what have you. And a lot of our normal transportation services that we provide service to that were, large users of our service, like the senior centers and nutrition sites, still haven't opened back up 100%. We're seeing that across the board with some of our agencies. Everybody's kind of putting the big toe in the water before they jump in. Nobody's wanting to jump in all the way. July 1 in North Carolina is a big date for us because it's the start of a new fiscal year, and we do look for some of those things to open back up, and hopefully our transportation will start to increase by then.
Thanks for letting us know about that, Herb. We'll come back, I think, to asking a little bit more about, maybe what some of the concerns of riders were in that time, and what you see, again, especially with this shift to telehealth, what you expect to see changing about the way that your service operates, what sort of trips you're providing, and what you see as sort of the role of transportation and in making sure that people can continue to connect to care. But first, Eddie, I'd like to ask, what was VIA's role in helping transit agencies as well as other transportation and health stakeholders address transportation barriers to the pandemic, or otherwise coordinating with partners to connect riders to care?
Thanks, Abby. And I think, as Olivia, Lindsay, and Herb have said, the pandemic was a major shock to transit systems across the board. And I think in the first phase of the pandemic, what we really saw was a real crisis, because we saw plummeting demand and service cuts that were affecting the most transit-dependent members of our society. Essential workers like healthcare workers couldn't even get to their hospital shifts. We saw grocery store clerks that couldn't get to the grocery store. And of course, we mentioned, healthcare workers and patients that couldn't even get to their critical healthcare appointments. And I think what really scared us was, in many cities, when you have these service cuts, if you have an outage, where you don't serve public transit at a specific time, it really puts the brakes on the critical infrastructure that was keeping our society moving during the pandemic. So what we really saw our role at VIA as was helping our transit partners adapt on the fly to these changing conditions. And I think the first phase of the pandemic was really focused on, how do you keep public transit working for these sort of essential use cases, even if it's going to be operating at 25% of what it was operating pre-pandemic. And there are a few different ways that we did that, and really, it was always adapted to local conditions. So for instance, in Tel Aviv, a large city in Israel, where VIA has a very large micro transit service. This is a on-demand public transit service. In March 2020, Israel shut down all public transit across the country. And this was a huge problem, of course, for the same reasons we mentioned before. What we wound up doing was, in a period of 2 days, we expanded that service from a coverage of just 3 cities around Tel Aviv to 6 cities. And what that allowed it to do was to cover all 8 of the regional hospitals in that area and provide free trips to healthcare workers and to help people get to and from medical appointments. I mean, this was accomplished in a matter of 2 days. And I think, because these services were designed to be sort of tech-enabled, flexible transit services, you could do that type of a transformation in a short period of time. We did a similar sort of transformation in Berlin, where we have a very large microtransit service called Barrelkönig. where we expanded the service within a matter of days to accommodate 75% of all hospital beds in the entire city. The other thing that we wound up doing with different transit agencies that I think was really interesting and innovative, and I wonder if there are some lessons for this beyond COVID. There are two in mind that I have, one in Malta and one in West Sacramento in California, where microtransit services were actually adapted to not only take people to and from their work or medical appointments, but actually to take food parcels and goods to vulnerable populations. So in West Sacramento in particular, there was a partnership with the local food pantry where they were doing regular runs to vulnerable people around the city, in the same vehicles that might be taking a nurse to his or her shift. The second phase, I think, of the pandemic, which really started, I want to say in December or January, was focused on vaccine distribution. And I think, as we all know, this is one of the bright spots, I think, of the US response to the pandemic, the vaccination campaign. And early on, I think a lot of far-seeing public transit officials and health officials noticed that transportation could be a major barrier to vaccination. And so what happened was we wound up partnering with some of our existing partners and new partners to facilitate access to vaccination sites. I think one of the most innovative of those campaigns was actually in your home state, I guess, of North Carolina, in Wilson, North Carolina, where VIA has a partnership there. There's a service called Wilson Ride that is a microtransit service that accommodates public transit for the entire city of Wilson. It's about 50,000 people. And really in a matter of days, with the support of the North Carolina Department of Transportation, the North Carolina Department of Health and Human Services, I think working more closely together than we normally see health and transportation departments, came together to put up funds and really thought leadership to enhance that service, to add a vehicle to the service, to facilitate free rides to and from vaccination appointments. And it wasn't just increasing the service availability and service hours. We also led a campaign to actually send notifications to everyone's phone and text messages saying, hey, this free ride does exist for you to get to and from a vaccination site. And I believe in the first few weeks of the service, there were almost 500 trips to and from vaccination sites. So they really, I think, accomplished a lot of their goals. And it wasn't just in North Carolina. We saw this in a lot of other states. Another one that I think is worth mentioning, just because it's quite interesting, is in suburban Detroit, Michigan. SMART, which is the transit agency there, had already sort of planned on launching a microtransit service in January with VIA. And really on the fly, in the middle of this launch process, while we were getting ready to launch, decided to add about a dozen vehicles to that service and add 4 additional zones to facilitate access to vaccination sites for free. And that also has accommodated hundreds of rides since that service has been live. So I think really our role, Abby, to answer your question was, working with transit agencies to build partnerships with healthcare departments and agencies, which they don't always have. I think ICPTA is kind of an example of one that has a great relationship with health, but you don't see that across the board in the United States. So we help them build those partnerships and then really adapt technology on the fly to respond to the health emergency.
Thanks so much for all of that context, Eddie. And yeah, I certainly want to follow up on sort of this idea of breaking down some of these siloed conversations that often happen between the transportation sector and the health sector. And again, sort of what players can come together to make sure that medical transportation is working, because ultimately, right, it's about facilitating connections between people and care. And so transportation is obviously the way to do that, but we've also talked about things like telehealth, but more adaptive transportation options, I think, are something that all of us are thinking about for the future. And so Herb, I want to sort of turn that back on you as a transit provider in a predominantly rural area with a lot of transportation disadvantaged users, and being so intertwined as a system with the regional health services, with Albemarle Regional Health Services. What are some of your key lessons learned from this really trying time, and how are you thinking about adapting your services? What's the future of ICPTA looking ahead?
So the key lesson learned in this whole pandemic is we're all in it together. And that's how we took the approach. Not only we are part of our local health department. Their region covers 8 counties. I cover 5, but not only with the health department, but Division of Aging, senior centers, everybody we do business with, all of our local DSSs, we all took the approach. We're all in it together, and we're going to keep going no matter what. So the biggest thing public transportation does, and the biggest eye-catching thing that I do to the political powers that be, being a rural system, is I keep people at home longer. You know, that's the benefit to the taxpayer. That's the benefit to the public, is people that would otherwise need to be in assisted living or be in a nursing home or be in an institutionalized setting get to stay home. They can stay home with their family. Their families can go off and work and be productive members of the community. And we can keep them in the medical appointments. We can keep them in dialysis. We can keep their cancer treatment going. So that's the biggest, brightest star that we are to rural North Carolina, or rural northeastern North Carolina. So I think what you're going to continue to see is I think we're going to grow some more, but we're going to grow slowly. We're definitely not going to come back as quick as the pandemic hit. Things are going to be entirely different than what they were before. Telehealth has worked out well. It's been wonderful. It's been wonderful for our clients. It's been wonderful for the people that use, but like y'all said in the presentation earlier, it's not a cure-all, because, you know, when that client doesn't get to go to the doctor's office and get triage and get their blood pressure checked and their blood checked and stuff like that, do their labs, you know, it's a lot of things that can be caught that will not be caught during telehealth. So we expect for things to continue to grow on our medical side. Our seniors in our area are still scared to death. Most of them have been vaccinated, but they're still not to the point that they really want to get in a setting where it's confined with a group of people. And part of that is simply because, as we all know, people that have passed away from COVID, and a lot of their friends and colleagues have passed away from COVID. One of the most detrimental things that's happened to us as an agency is we've lost maybe 15% of our ridership through this pandemic. And typically we'll lose 5 to 10% a year anyway, because of a lot of our clients are older in nature, and a lot of them are sick or they have medical issues. But typically when we lose 5 or 10%, we gain new clients to that ratio, except for maybe 1% or 2 more. So if we lost 10%, we typically gain back 11% in new clients. But when COVID hit and the pandemic hit, we saw no new clients. For the most part, we saw one here and there, but they were, you know, dialysis clients or whatever. But we had, just on my advisory board, you know, that kind of keeps me pointed in the direction the community wants to see me go. I lost 2 of my advisory board members out of 10. It was, you know, it's been very detrimental to us as a community, because, like I say, people are still scared to get in those settings. And when you start talking about putting them on a vehicle, they're confined. We've done everything we can that I know that I can do on the vehicles to alleviate some of that concern. We put HEPA filters on all the vehicles to purify the air in the vehicles. We disinfect the vehicles every day. As FDA still states in CDC, we're still requiring masks by everybody on the vehicle because it's a confined space. But I think it's going to be a long road to hoe before people start jumping back on us like what they did before. You know, a lot of the clients that we've ridden in the past are elderly people that maybe didn't get out before, that would request to ride. They'd ride to Elizabeth City from 2 counties over and get off for 15 minutes and do whatever they need to do and ride back. And it didn't have to do with where they were going. It had to do with they just want to ride around the area and see what was going on. But we're just not transitioning back as quickly as I would like to see. And until things lay down on a national level, on a world level, I don't know how fast that's going to come back. But we're going to continue to be here, and we're going to continue to provide the service that we do provide to the community. And the one thing I do not know if we will ever go back to is we're a fare-free system now. With COVID, we quit charging fares for anything. I don't know if the juice is going to be worth the squeeze to collect cash from clients anymore. And I know like Eddie's company has it to where they can do it via credit card, or, you know, their company has all kinds of technological facets that will make it work for the provider, but we're still in a rural enough setting to where a lot of our clients don't have smartphones. A lot of our clients don't, you know, a lot of them don't even have a cell phone, and it's just, and they're happy. So we try not to push anything on them that they don't know. So does that answer your question for the most part? Probably a little extra.
No, it's perfect. And I'm going to ask, I think, Eddie to respond directly to that, and maybe also orient his answer to describe sort of what you think, Eddie. How can transportation stakeholders from various sectors and healthcare stakeholders as well collaborate together, again, looking ahead to plan these sort of resilient, sustainable, again, even facing these conditions where maybe we can't continue collecting fares, for instance, as well as health promoting transportation systems. How can these systems continue to connect people to care, operate, et cetera, looking ahead? What can we do to make sure that the right people are talking to one another, that the right technology is going where it needs to go, and that ultimately people are getting where they need to be?
Sure. Thanks. And Herb, I mean, that was a really moving comment you gave about your colleagues and about what's going on in Elizabeth City. And my condolences to you. I know we've seen that in so many other communities. I do think that technology does have a really strong role to play. And this is something that we've seen with our partners that already had imposed sort of technology on their services that allowed sort of services to be held on demand, to allow contactless payment. It was a lot easier, I think, for a lot of those services to adapt overnight. And so I do think that if there is one lesson I have from sort of a technology company lens, like I do think that it's never too soon for a transit agency to start working with a technology provider to really try to bring their service into the 21st century. And I think you can do a lot with an amazing staff and pen and paper, but you can wind up adapting a lot quicker to emergencies, I think, if you have the assistance of technology. I think there's another lesson I want to talk about before I pivot into your question about collaboration, because that's the real thing I want to talk on. And that's just, there's really no substitute for public transit. And I think this is so important because, in the last decade with the rise of some of these ride hailing apps, and, there's I think some people have thought, oh, well, is public transit the way of the past, and, we don't need it anymore. I think what we've seen in the pandemic is that, if all of our transportation options just respond to profit motive and market signals, when we need it most, it's not going to be there for us. I think, Olivia, you started off with a really good point, which was, ride hailing services have just been less available during COVID. And that's because you can't make as much money as a ride hailing driver right now as you probably could 2 years ago. And so, if there's really one lesson I have, it's that we need to make our public transit systems more robust and not less so. And because when we have an emergency, they're going to be the backbone. In terms of collaboration, I mean, if there is one hope I have for transit coming out of the pandemic, it's that these relationships, like frankly Herb has in the Albemarle region, with public health departments, with hospital systems and transit, that they just become sort of the regular order of things in the United States, because it's hard to build those relationships on the fly. And when we have another health emergency, it's going to be important for those to be in place. Two examples, and then I'll turn it back over to you, Abby. In late 2020, so I want to say about 8 months ago or so, we worked with a transit agency in Bakersfield, California called Golden Empire Transit to launch a service that is microtransit, so that's on-demand public transit, paratransit, and non-emergency medical transportation. So this is Medicaid-funded medical transportation, all in one. And I think that a service like that, where you're sharing vehicles, you're sharing technology across those three different services, A, you can make it much more sustainable because you're saving money. B, you can have fewer vehicle miles traveled, so you reduce congestion. And C, you just make this a much more accessible service because you have people crossing over from the NEMT to the paratransit to the microtransit side. And it doesn't always have to be with the Medicaid agency. I think that can be helpful, but even in a service we did at a similar time in Northern California called the Shasta Regional Transit Authority, that regional transit authority is actually partnered with the local hospital system, Dignity Health, to have a similar service. So I think if I have one sort of hope coming out of the pandemic is that we'll see public transit agencies, state Medicaid agencies, hospital systems, really public, private, nonprofit stakeholders coming to the table to build these resilient health transportation systems of the future.
Yeah. I mean, Eddie, it sounds to me like these resilient systems, and her view as well, right, are going to rely not only on the ability to make, sort of a nimble pivot, maybe on a dime with some of these technological advancements, sort of, again, laying the groundwork so you have some of these technologies in place. There's some, institutional knowledge of how to use them, and then, employing those in potentially a new and important way, as you gave in the examples where there was, an expansion of service or an expansion or change in microtransit services that were already in operation, but maybe shifted their operation, shifted their purpose, shifted their trip, shifted their service area during the pandemic. But even more important, again, may be already established connections between the right people who are a part of this system of service, who are part of getting people to medical appointments, to medical facilities, to treatment, to healthcare, to where they need to go otherwise. And so making sure that health partners are talking with transportation stakeholders, with technology companies and others to get there. So I definitely, again, want to come back to that experience, but I also want to give our audience a chance to speak up, to join our conversation here. So Lindsay, if you wouldn't mind sharing the screen again. Okay. So we will very soon open up our webinar for questions. So if you haven't already, please enter any questions you have in the chat box. We, with the Stride Center, also ask that you please complete a brief 5-question survey at this time using the link in the chat box. This will help the Stride Center plan their future webinars. Yes, I see that Stride Webinar has just added that link to the chat box. So I'm going to give everyone 1 minute here to complete the survey and submit your brilliant questions. Give our speakers an opportunity to take a sip of water, take a breath. All right, if you could advance to the next slide, Lindsay. We'd also like to take this opportunity to let you know about some upcoming Stride webinars. In 2 weeks, on June 30th, I'll be returning with colleagues from UNC Chapel Hill, as well as speakers from North Carolina State University and the North Carolina Department of Transportation, to elaborate on transportation's critical role in the COVID-19 vaccine rollout, which Eddie and some others among us alluded to in this webinar. So I think that should be a really interesting conversation. If you'd like to register for this webinar or others, please go to the Stride website link that will also be provided in the chat box. So we are now going to transition to audience Q&A, but it seems, however, at this moment that the audience is still brainstorming, still mulling over all of the extremely interesting and important comments that were made during this webinar. So I will jump in with other colleagues and continue asking questions of our speakers because I would love to continue this conversation. But if the audience has questions at any time, again, please do put them into the chat box. and we're all happy to answer on anything that's been presented on today. Herb, I wonder if we can spin it back to you a little bit. I know that you're planning some changes in service offerings and operations in the Elizabeth City area. And I'm wondering what you see, how you're envisioning that service, what sort of instigated the change, and what you're hoping to gain out of offering a more on-demand service option.
Oh, we are extremely, extremely excited about this. So really right before the pandemic started, NC State University, the Institute for Research and Transportation Education reached out to me along with NCDOT and asked would we like to be part of a program that incorporated NC 360, NC Cares 360 with public transit. And what that means is it's an FTA grant, and it basically is using technology such as Eddie has to connect public transportation to any kind of human service agency within the region that we serve, or really throughout the state, but they would be able to schedule transportation directly with me. And the goal of that is to basically put a portal in these other human service agencies' hands, such as, again, DSS, mental health providers, Division of Aging, any human service agency, to where they could directly schedule a trip within ICPTA system. You know, we've been working on this, like I said, pre-pandemic. The pandemic slowed us down a little bit, but we're just about to get all the way through it. We're hoping that we can offer on-demand services. We don't have the contract straight with the vendor yet, but we're really, really close. So we're hoping that maybe by August, September, we're going to be able to offer some on-demand transportation, whereas right now, our demand response service requires a 48-hour notice. We're looking for the efficiency of our transportation to go up. The current technology we're using right now does not work very well when it comes to laying out routes and laying out trips. You know, I've got 4 girls that stay in the front office that dispatch and schedule all day long, and they're constantly trying to manually decide what trip fits best on the next route. The version, what we will be going to, the technology will take care of all of that for them. We'll actually be able to move our dispatchers into turning into actual dispatchers as opposed to scheduling and dispatching. Back to what Eddie said, technology is where it's at. Technology is what's moved us. It is what's kept us being a progressive transportation system in the state of North Carolina. You know, when years ago we ran into the state of North Carolina and the local governments ran into some financial issues. The money wasn't there to provide trips that it used to be there. So we incorporated propane on our vehicles, which saved us a ton of money, so we could offset the money that we lost in state and federal funding with local dollars. So we were able just to do more with less. Technology is going to help us do that as well, but it's going to be at a lightning fast speed. The technology is proven. It's across the country. What Eddie's doing is what VIA does works. It's well documented throughout the country, throughout the world. You know, communication has to occur through technology. And it's the only way that we're progressively going to be able to keep things going in an efficient and effective manner. Like he said before, pen and paper, you know, is nice. And even what we have now is nice. We have tablets on the vehicle. We can see in real time where a vehicle is and who's on board, but moving it up to the next level is where our clients are going to benefit the most. Because when we move it to the next level, the clients will be able to see where the vehicle is. If a bus is out at 6:30 in the evening and there's only one person at the office and they can't get through to the office, they'll be able to pull up on their smartphone. They'll go to the internet and pull up and see where their loved one is, who's on the vehicle, where it's going, and when it should be there. That, along with IVR service, which is night before trip notifications and 15-minute trip notifications and 5-minute trip notifications before the vehicle arrives is only going to do things to increase our efficiency as a transit agency. So we will not be able to move to the next level without technology, and those that ignore technology are going to have a difficult time. But it's there, it's at our fingertips, and we're willing and ready to use it to make us a better agency, not only for ourselves, but the community we serve.
Yeah. Thank you for those comments, Herb. And I would like to ask a little bit more, but maybe this is for a future webinar, about how you might sort of pull more of those transit dependent populations that often have less access to technology and may be encountering more barriers to transportation right now because they remain very anxious about using the vehicles, or again, have some other barriers that we've discussed during this webinar. How you're sort of planning to pull them in again to this, more technologically progressive space. And I'm sure Eddie also has a lot to comment on that particular.
We're ready for that. I think we're ready for that anyway. So what the intention of my intention of doing that is we intend on taking some of our employees that are doing things manually now that won't have to do it manually in the future when we move to our next technology platform. We intend on taking them and turning them into educators. Currently, we run into that even with the people that are technologically challenged. We've got clients all the time that say, I would really like to ride your service, but I'm scared. I don't know what the bus is going to be like. I don't know what it's going to be like to be on the vehicle. And we actually have staff employed here whose job is to go out, take a vehicle to that person's house, meet with the family, meet with the person, allow them to get on the lift, ride up on the vehicle, so they can see how much room they're going to have, so they can see what it's going to be like to ride on the vehicle, and they can start building a relationship with us as an agency. COVID was wonderful for this. If there's any bright stars in COVID, this was it. When we started our reverse transit to actually put a nurse on our vehicle and take the vehicle to homebound clients home to give them the shot, so we didn't have to put them in with other people. That gave them the opportunity to say, hey, well, let me look at the vehicle while it's here, or the family members, well, I didn't really realize you would come get us and pick us up. So it's all an education piece. And the more we're out there, the benefit of being in a rural community, in a small community, is everybody knows everybody, and everybody's in everybody's business. That's not always a good thing. But when you're trying to serve a population and somebody says, I don't know how I'm going to get my uncle to the doctor next week, I've got to work, and they've got a family member or a coworker that says, well, why don't you just call ICPTA? They took my grandmama to dialysis and it worked out well for us, or that's who my mom uses and they love it. So it's going to be an educational process, but I think we're geared up for it and we're ready for it, and we're laying out plans right now to make it happen, hopefully.
Great. Thanks so much for sharing that, Herb. Eddie, any comments on that?
Yeah, I mean, Herb said it really well. I think the thing to add is sometimes when people hear the word technology, they think that, oh, this is all about using a smartphone and what happens if my community doesn't have people who use smartphones. That technology is only part of what we're talking about. And actually, it's not even the most important part. The most important part is this dynamic routing, scheduling, ride assignment that's happening really in the back end. So even if, there are services that VIA works in where 50% of rides are booked via, call-in, just a regular call center, right? That doesn't mean that the technology is not working, right? The technology is still working to schedule the rides efficiently, to route the drivers, from dynamically turn by turn. So I think that the nice thing about when you actually do automate some of these back-end functions that Herb mentioned, such as scheduling and routing, you free up staff time to do what only humans can do, which is human connection. And I think that if you're thinking about what the highest and best use of all of us is, it's really, reaching out to other people, making them feel comfortable, educating them. And I think that, the hope is that if technology can work in sort of automating some of these tasks that are more repetitive, that we will free up staff to be able to do exactly what Herb and his team at ICPTA have been doing to educate the people in their community.
Yeah, well, thanks so much, Eddie. And on that note, I think I want to make sure to respect everyone's time. I think we've hit our end time for the webinar. So thanks to all of the speakers. Thank you for joining us today. I think it's been a really enlightening and interesting and important discussion. We did end up getting one sort of last minute question from the audience. It says, do you have any thoughts on the future financing for public transit or health transit? Any innovative / new ideas? I wonder if whoever sent that question could get in contact with one of us. Lindsay, maybe you'll bring up that final contact slide real quick and direct it to whoever you'd like to answer, or CC all 5 of us, and we'd be happy to share our thoughts. So thanks again to everyone for being here. Thanks to everyone in the audience, and thank you to the Stride Center. Enjoy the rest of your day.